I'm Steve Hodgson from the British Society for Surgery of the Hand. I'd like to thank yourselves for joining what we hope will be a very useful afternoon. Particularly want to thank Samuel and Peter from Tanzania, who are our local organisers, and Emma Brighton from BSSH Secretariat, who's providing the IT support. You must be aware that there's some fairly old surgeons teaching this afternoon, and our IT skills are not quite as good as we would like, and we certainly need Emma's support. So British Society for Surgery of the Hand and the British Foundation for International Reconstructive Surgery and Training, that we call, otherwise known as BFIRST, are very committed to supporting the development of hand surgery in Africa, and particularly doing that by educating the surgeons and their teams. This does build on 3 visits we've done to Tanzania, starting in 2019 and carrying on until COVID put a stop to it, and also on Jonathan's visits to Malawi and Uganda. So we're very keen that it's part of the Kasetska family that we're delivering this for. I'd like to introduce the speakers. We've got Jeremy Field, who's a surgeon from Gloucestershire. Well, welcome, Jeremy. Jeremy is a renowned hand surgeon in the UK, former chair of the AO UK hand and wrist courses. We've got Jonathan Jones, who's the current chair of the British Society for Surgery of the Hands Overseas Committee. He's a consultant hand surgeon in Cambridge and Peterborough. And Subodh Deshmukh, who's another great speaker who works in Birmingham, another consultant, orthopedic background hand surgeon. And I've already introduced Samuel and Peter from Tanzania. As I say, the project was going well with face-to-face meetings till COVID, and I do hope that COVID isn't having quite as big an impact in Southeast Africa as it has had in the UK. Pleased to report we are coming out of wave 3, but it's had a real impact on particularly our elective services, which have almost ground to a halt. But we do hope that you are coping with COVID and that you start to see light at the end of that tunnel. And we look forward to further visits when that becomes possible. I'd just like to advertise a couple of events. This is the first of 2 events that we want. There is one next week, same time, same place, on tendon injuries. And then in late April, BSSH BFIRST monthly webinar program restarts. That's a 2-year program. The first one, I think, is April 23rd on the mutilated hand. And then over the 2 years, we will cover the whole hand surgery syllabus. We hope to have one on hand infections later in the year with Kasetska, and still have ambitions to come out to Moimbili to deliver a hand and wrist trauma course. So do look on the BSSH website, and you can register to receive flyers for all of these educational efforts. We start really almost at the beginning for hand surgery. Not quite at the beginning, because hand anatomy is probably the real starting point for being a hand surgeon, and we assume knowledge there. But this session is covering hand examination, assessment of the injured hand, and imaging of the injured hand. As I say, we've got 3 really good speakers, and then some case discussions to tease out that learning and reinforce the learning. So you're all muted, but you are very welcome to put questions in the chat function, and I will field them for the speakers after each of the presentations. Again, during the case discussions, you will be issued with electronic certificates after the event, and we do encourage feedback. So, please do let us know what worked well, what didn't work quite as well, because we always learn from each event. So if I can now hand over to Samuel, who's going to say a few words of welcome on behalf of Kasetska.
Yep. From my side, in the actual fact, I would like to thank the British Society for Surgery of the Hand and their charity partner BFIRST for realizing this webinar and the previous courses they have held in this part of the world. Hand trauma in this part of the world occupies about 5 to 10% of our patient burden at our emergency services. And about 1% of those cases are admitted with the complex injuries of bone injuries, soft tissue injuries, including tendons. And for example, in Tanzania, we are yet to register or have hand surgeons. It means that the surgeons dealing with the hand injuries is our skills through causes we deepen and gain our this is just a glance from this part of the world, and I hope our experience, skills, and knowledge from you. This is the first webinar, but we have a series of webinars, as you have said, and the causes which will depend on how the situation evolves. Thank you very much for organizing or realizing this webinar. Thank you.
You're welcome, Samuel. Jeremy, do you want to share your screen and give your talk on the important topic of hand examination?
Unmute. Jeremy is on mute.
Is that right? Can everybody hear me?
Yep.
Yes.
Yes.
Yeah. Hello, my name is Jeremy Field. I'm from a place in England called Cheltenham, which is the only real thing it's famous for is horse racing, and it happens to be the horse racing meeting now. So there's a lot of horse racing going on around where I am. We're going to start off with some hand examination. This is quite basic to start off with because I give this talk to registrars, but I think there's going to be a test halfway through. So I want everybody to have a piece of paper and a pen, okay? And hopefully if you can get that now before we start, that will be a brilliant thing to do. But greetings, it's a real honor to have to talk to you, and thank you very much indeed for asking me. Off we go. So I'm going to talk about some general top tips, which I generally give to my registrars for passing the exam. I'm going to talk about surface anatomy, which I think is something that we all forget about a bit, and I think it's quite important. I think it's absolutely vital. And now I'm going to talk about examination. So firstly, the top tips are look, feel, move. We all know these age-old orthopedic elements to our examination, and they are absolutely vital. But the most important thing is that 90% of your information comes from looking. So please spend time looking. And the test we're going to do is just to encourage you to look, and so that you can use your eyes. Always, when you're examining the hand, compare both sides. It's absolutely vital. You will see horrid anatomy in the other side of an injured hand and get totally confused if you don't do that. So always examine both sides. Be systematic in your examination. Start proximally, particularly if you're examining something like a rheumatoid case. Start proximally, and you start up, for example, a rheumatoid, start with the neck and the shoulders, and then go down to the wrist, and then go down to the hand. Common things are common. Now, the common things that I've got down here are pretty common in the UK, and they may not be things that are common in East Africa. And if they're not, then I'm sorry about that. But I think the same thing applies. Whatever is common in your country will be common, and those are the things you're going to see. So in England, we're talking about rheumatoid, osteoarthritis, ganglions, Colles fractures, scaphoid non-unions, and Kienbocks, and perhaps Colles fractures and their malunions thereof. This is, again, terribly basic stuff, but I think it's so important to to be able to examine a lump properly. And so you can describe it to someone over the telephone. And there is this rule of S's. So site, where it is, the size of it, the shape of it, the surface, the solidity, and the fluctuance. Fluctuance is something that a lot of orthopedic surgeons don't know how to do, and I don't think they should pass any form of exam if they can't detect whether a lump is fluctuant or not. If a lump is fluctuant, it's full of fluid, and the way you do it is you press with 2 fingers on the lump, and then you press on the middle of the lump, and you watch your fingers expand. And I'm sure you know this, but it's very basic stuff. You want to see whether it's see-through. That means whether it's actually got fluid and clear fluid in it. You also, what everybody forgets is examining the surrounding structures. So if you've got a lump in the hand, always examine the elbow, always examine underneath in the armpit. Also pulsatility. So we're going to do some surface anatomy, some basic surface anatomy. So I want everyone to actually examine and feel their own wrists as you go through these slides here. So the radial styloid, very easy to feel. Lister's tubercle over the back of the radius. Now we all know that EPL goes round this, and if you go just distal to the Lister's tubercle, you find a dip in your wrist, and you can feel that dip in your wrist, and that's where you would aspirate a wrist if it's got a septic arthritis. And actually distal to that, you find the scapholunate joint. So in between those two is where you would aspirate a wrist. This is the distal radioulnar joint, which again you can easily feel on your own wrist. And if you rotate and pronate and supinate your forearm while you're feeling this, you can actually identify where the joint is. Now, I hope everybody knows what this is. This is the lump on the back of your wrist, and it is not the ulnar styloid. That is your ulnar head. Your ulnar styloid lies quite a lot volar and also quite a little bit distal to where your ulnar head is. Your triquetral tubercle is palpable. Now, this is the thing that comes off on triquetral flake fractures, and this is one of the few important ligamentous injuries from the back of the wrist. And any ligament that you find that is ruptured, and if you see a triquetral flake pull-off fracture, that needs to be immobilized for 6 weeks, because that's how long it takes a ligament to repair. The extensor compartments, again, I'm sure you are all very much aware of these, but you must know them and know exactly where they are. Now, your wrist creases, this is an interesting one. Now, if you look at the most distal wrist crease, I think most of us would know that probably is the radiocarpal joint. In fact, it's not. I'll shut up now. The most distal crease is the most proximal extent of your flexor retinaculum, so your carpal tunnel. The middle crease is your radiocarpal joint. Now, I always say when I'm giving this talk that anybody can tell me what the most proximal wrist crease is that you have on your wrist, I will give them £10. So in your country, perhaps I give you $10 American. If anybody can come up with the answer to that, I'd be very grateful. They have to do it pretty quickly because I'm going to tell you. It is, in fact, the proximal extent of your flexor tendon sheaths. So if you look at the distal crease in your palm and you go towards the radial side, you will identify your scaphoid tubercle. That is a lump, and it's a round lump, and you know it's your scaphoid tubercle because if you ulnarly deviate your wrist, you find the scaphoid tubercle disappears. If you radially deviate your wrist in neutral, you find your scaphoid tubercle becomes more prominent. This is because the scaphoid rotates with radial and ulnar deviation. Once you've found that, so I hope everybody can find their scaphoid tubercle. The pisiform, you go straight along that crease, that distal crease towards the ulnar side, you'll find your pisiform. Again, you can blot your pisiform and find out if anybody's got pisotriquetral arthritis. If you go more distal to that, we can see the hook of the hamate, and you can roll your ulnar nerve around your hook of hamate. You know that the ulnar nerve goes radial to the pisiform and ulnar to the hook of hamate. And across the other side of the wrist, sometimes, if you're really clever, you can feel the trapezial ridge. I think this is a difficult one to feel, but certainly you can feel it if you try hard enough in a thin palm. Your palmar creases are important in the fact that anything that's really important is the fact that the only crease that actually tells you where the joint is the PIP. So the crease over the PIP of your fingers shows you where the joint is. The creases on the rest of the palm do not show you where the joints are, and the slide on the right shows you where the joints are. So I hope that everybody knows whose line this is, and I hope that everybody knows what it marks. But essentially, it's Kaplan's line, and it marks the distal most aspect of the flexor retinaculum. It marks the superficial palmar arch. It marks the thenar branch of the median nerve. So if you bend the middle finger down to that line, you'll find that's where the superficial branch of the median nerve is. Now, here comes the test, okay? So I want to get you to use your eyes. And there are going to be 15 questions, and I'm going to go through these quite quickly, but I'm going to give you time to look and get the answer. But please listen to the question, because there's going to be one question for each slide. So the first slide, the question is, what is the most obvious abnormality here? Question number 2. What is the clinical sign that you see here, and why? What is this patient's occupation? You can tell me what sign it is as well, but I want to know what the patient's occupation is. What clinical sign do you see here? And what is the likely diagnosis? This is not vitiligo, by the way. What clinical sign do you see here? What is the diagnosis of this lady's hand, who is holding a wine glass? This is the index finger of someone who's been injured with a knife. What clinical sign do you see? Tricky, that one. The experienced ones may not get that one. What do you see on this slide? Look at the whole slide. Look, look, look. I want to know what you see. What is the abnormality here? This is question 9, by the way. Question 10 is, what feature is odd about this hand? Another difficult one, that one. What feature is odd about this hand? Number 11, there are 3 clinical differences between each hand on this slide, and I want you to tell me what they are. As you can see, there's an ulcer on the side of this hand. What's causing that ulcer? Number 13, what is this? What is the diagnosis? Question 14. And the last one is, what does this slide show? Now, you're going to have to mark yourselves, obviously, and I want you to be entirely honest, okay, with each other, and see how many points you get. So we're going to go through them again, and I'm going to tell you what the answers are. What is the most obvious abnormality here? The most obvious abnormality here is this lady has not got a thumb. What's the clinical sign you see here, and why? The little finger has got no skin creases along the flexor side of the finger. And obviously, if it's not got any flexor creases, it means it hasn't been bending, so it's probably a tendon injury. So that's the diagnosis. What's this patient's occupation? Well, it's a farmer or some kind of manual worker. And I think if you say a mechanic or something like that, I'd allow you. Anything that gives you dirty, horrid fingernails. And that's obviously showing Froment's sign, which is a sign of an ulnar nerve lesion. What clinical sign do you see here, and what's the diagnosis? This is a steroid-induced depigmentation of the skin, and the diagnosis of the patient is decurvanes. That's the dorsal radial side of the wrist. What clinical sign do you see here? This is wasting the first dorsal interosseous from an ulnar nerve lesion. What's the diagnosis of this lady? This lady's got osteoarthritis at the base of her thumb. You can see that she's got an abducted first metacarpal, thumb metacarpal. She's got a hyperextended MPJ of her thumb, and you also see shouldering of the base of the thumb. This is an index finger that's had an injury. And what's the injury? The injury is a digital nerve injury, because you can see the contour of the dorsal aspect on this slide is different to the contour on the volar side of the thumb. It's just gone straight towards the pulp, and that's a digital nerve injury. Told you that was a difficult one. What do you see on this slide? The first thing you see, obviously, is an arrow, and it's black, and it says CTD at the top. So that means carpal tunnel decompression. That patient's going to have an operation. But obviously, you see also wasting of the thin remnants. What's the abnormality here? This is an abnormality, the swelling of the index finger, and that is from a flexor synovitis. What feature is odd about this hand? And the feature that's odd is the fact the middle finger is not the longest finger. And the reason that is, and some may say, I think it's the ring finger's long. And the answer is the middle finger is short, because you can see over the back of the MPJ of the middle finger, you can see it's swollen there, and there's an old scar. That this gentleman had an MPJ arthrodesis. What are the three changes you see, the differences between the sides here? Firstly, there's swelling of the fingers. Secondly, the skin is more shiny. Thirdly, there's increased hair growth. And another thing is reduced skin creases over the PIPJs of both sides. That really is indicating swelling. What's the cause of this ulcer? Well, this is a lady who's got ulnar drift of her metacarpophalangeal joint. She's got a transverse scar over the dorsal aspect of MPJs. And that scar there, which I think is isolated now, is an MPJ replacement, silastic MPJ replacement that the wound hasn't healed over. So that's what that was removed. What is this? This isn't some kind of funny skin lesion. This is a protruding piece of metal. This is someone who's had a DIPJ fusion with a screw, and that screw is becoming prominent. What's the diagnosis here? This is not a pulsatile lump. It's a firm lump on the volar aspect of the wrist. In fact, it was a rheumatoid nodule. And what does this slide show? Now, when I show this to perhaps not experienced people, they all say it's a foot, which of course it looks like a foot, but it isn't a foot. And obviously, you know it's not a foot, but it's this person got their hand caught in a threshing machine, and you can see the volar scar from the fasciotomy wound. Now, add your points up and see how many you get, and you can tell us at the end. It doesn't matter how many you get, but I'm asking you to use your eyes, and I hope that you'll get the impression that that is the most important message from this talk. So we've done looking now. We now go on to feeling. So you feel the bones and the tendons and the landmarks, and you do it quickly and systematically. If you find someone that's got radial-sided wrist pain, they have either got scaphoid pathology, scapholunate pathology, decurvanes, or thumb pathology. On the ulnar side, you've got TFCCs and ulnar heads and DIUJ problems stop. The 3-place test for the ulnar-sided wrist pain, you press over the ulnar head and blot it, and that is supposed to indicate DIUJ pathology. Just distal to the ulnar head is where the TFCC sits, and just distal to that is the triquetral-lunate joint. Testing for radioulnar joint stability, you can actually do this yourselves, but you can't do it on your own, I'm afraid. So if you were in a lecture 30, you could do it with your neighbor, and unfortunately you can't do that here. But if you try and do this to your wives or partners or lovers or whoever it may be when you get home tonight, hold the wrist in neutral with one hand, with the left hand, and then you get hold of the ulnar in between your index finger and thumb, and you can actually translate to and fro from dorsal to volar and find out how stable your DIUJ is. The most important thing about this test is that when you radially deviate the wrist, that wobbly DIUJ stabilizes. And if it doesn't stabilize, then you've got a distal radioulnar joint instability problem. And then you move. And I've said, again, you compare both sides. So a great way of examining the wrist is by doing it both hands. So asking the person to try and pray, to look at dorsiflexion, try and put the hands, the backs of their hands together and their elbows down to detect volar flexion. Radial deviation is interesting in the fact you can see on the X-ray on your on the right there. I'm trying to move something. Here's the fact that your scaphoid has got a ring sign on it, and that means you're seeing the scaphoid end on. And don't forget, when you did your examination of the wrist and you felt your scaphoid tubercle, if you radially deviate your wrist, the scaphoid flexes and you can feel your scaphoid tubercle. And so you see the X-ray of radial deviation, you see a ring sign on the distal pole of the scaphoid. When you ulnarly deviate your wrist, you can see that the scaphoid extends and you lose the ring sign. The Kirk Watson shift test, scaphoid shift test, is again feeling along that distal palmar crease to find your your scaphoid tubercle, and you ulnarly deviate the wrist to make sure that the scaphoid tubercle disappears, and then you forcefully press on that area where the scaphoid tubercle was, and then radially deviate. So what you're trying to do is stop the scaphoid flexing. And a positive test was originally described by Kirk Watson as a clunk. My feeling, and I hope that my other learned colleagues that are with us today, my feeling is that if you get dorsal pain during this test, that to me is a positive Kirk Watson's test. Pain over the scaphoid tubercle is not a positive Kirk Watson test. So looking at pronation, supination, don't forget to keep your elbows into the side. You must stop shoulder movement. Hand examination, essentially extension of the fingers and flexion of the fingers. If there are any physios watching or hand therapists watching, the hand therapists all call this gross composite flexion to the palm. It basically means you're getting all your fingers into the palm, and that you want to make sure that your patient can do. And sensory examination is on the volar side on the left slide here, and it's on the dorsal side on the right. Just don't forget, and I always do this, and I don't know whether my other colleagues do, but if I'm trying to do something like a mucus cyst excision or something or doing a DIPJ fusion, if I'm doing it under local anesthetic, I always stop a little bit of local anesthetic on the dorsal aspect of the finger just to make sure that the radial nerve extension doesn't get up there. So I might do a volar block to a metacarpal block with some local anesthetic, but I always put a little bit of local dorsally. And just lastly, I want to go through thumb movements, because these have changed, and the Hand Society, in our wisdom or their wisdom, have come up with some lovely movements for these. So on the left-hand side, I don't know what that movement is called, but you probably know it. You can speak it to yourselves or speak it to your computer, but it's thumb flexion. Now, this movement on the right is not what you think it is. It is not extension. It is now called radial abduction. Despite the fact that we haven't got a radial abductor longus muscle or tendon, that's what it's called. It's not called extension anymore. So on the left, we have got palmar abduction. It's got radial abduction and palmar abduction. And on the right, the movement, I think, hopefully you all know, is opposition. And lastly, this one is now called retroposition, not retropulsion. So in summary, things I want you to take home are 90% of your information comes from looking at, and I know that Jonathan's going to advocate this as well. Always compare both sides, always, always, always. And don't forget your basics, how to examine a lump and causes of, etc., etc. Thank you very much indeed. Questions, please. Well, it might be nice actually. It might be nice actually. I don't know if Emma can do this, but if they can actually tell us how many points they got out of for the test, but they don't need to do that.
Welcome to share it in the chat box.
So thank you, Jeremy. If people want to if people have any urgent questions for Jeremy, could you post those in the Q&A chat box, and I will ask Jeremy. Somebody got 9. That sounds pretty good. That's
pretty good to me. Yeah, yeah. 2, 3, 4, 5, 6, 7, 8, 9, 10.
And then we have a score of 11 out of 15, which is very impressive.
It's very impressive.
That's Ronak.
Yeah, that's very good. Well done. Well done. Well done.
So I've got a question about how easy is the surface anatomy in obese patients?
It's like everything, isn't it? Everything's more difficult in obese patients. So I mean, you haven't got a hope in hell of finding your trapezial ridge in a fat palm. But one of the joys about hand surgery is the fact that when the patients are obese, they're obese everywhere apart from their hand. So the hand tends not to have a huge amount of fat on it, and that's why one of the reasons I always try and persuade my trainees to do hand surgery, because it's much easier really than general orthopedics. Does that help?
And then there's a question which I will direct to Jeremy because it's complex. Should we not be describing thumb extension then? Should we not be using the term thumb extension then?
Well, the Hand Society says not. It says we should be using radial abduction. I'm afraid that I use extension. So I think that extension is a much more sensible thing to say, because we have a muscle that does it, i.e. extensor pollicis longus. But officially, if you were in an exam, you should actually use radial abduction rather than extension. But if I was in an exam situation, I would say, oh, but I still call it extension because that's what the muscle's called.
And then somebody is asking a question about the first picture displayed, which may be the one that was lacking the thumb.
It was the one that hasn't got a thumb in it. And that's why I particularly said, what is the most important abnormality or is the most obvious abnormality on that picture? And that is the fact that that patient hasn't got a thumb. Now, obviously, there's a lump on the back of it. And in fact, it's a lump on top of a lump, isn't it? If you actually remember it. And in fact, it's a rheumatoid wrist. And that lady had lost her thumb from a traumatic event. It was nothing to do with the rheumatoid. But that's what I was trying to get you to say is look, and answer the question. So what is the most obvious abnormality of that slide? And the most obvious abnormality is the fact there ain't a thumb there.
Okay, that maybe just let me. Yep, no, I think that's the final question. Lots of scores ranging from 4 up to 11, so
that's very good. I think that I think you could. I think there are probably about 18 is top mark, but yeah, brilliant. Well done for getting 11. I mean, I think that's pretty good. I don't think I would get 11 if I saw those, and I haven't seen them before.
No, and I don't. What's the highest score you've ever done when you've run that test?
I've never run the test before, so this is the only time. But I think you'll find there are 18 possible points there rather than 15.
Right.
But I'm not asking for points. This is not a test to see who's the best. I'm not interested in that. What I'm interested in is me teaching you to use your eyes.
Yeah, and then there is a question coming about how do we check the FDS of the index finger?
How do we test the FDS of the little finger?
It says index finger, but
well, we
similar for all.
Hand flat on the table, and you block movement of the middle ring and little fingers, and you ask the patient to flex the finger. And if the DIPJ moves, your FDS is intact. But you can also, so you have to block the movement of the other fingers, otherwise you'll get the compound action of the muscle. So you have to block the other fingers and keep them extended in order to test the flexion.
You mean the PIP, Jeremy? Not DIP.
I mean when you're flexed. Did I say DIP?
Yes,
I meant the. Thank you, Stupod.
I'll still away.
PIP is what I'm trying to say.
May I ask one quick question?
Yes.
Jeremy, with COVID-19 SARS pandemic is with us. We are doing consultations in different ways, telephone, video consultation, and face-to-face.
Yeah.
Some of the elegantly displayed examination techniques that you've done today work very well over the video medium and in video consultations. Do you have any thoughts about that interface as opposed to face-to-face?
It's really interesting, isn't it? Because although I've done a few clinics over the video and Zoom and Teams and things, I've had to do quite a few medical legal reports, and I find actually that it's really pretty easy to get an accurate examination. You can actually tell patients what to do. You can demonstrate what to do. So if no one can probably see this. I don't know. Can anybody see me doing this? Would I, if I unshare, do you get a picture of me then, Emma?
Yeah.
Yes, you should do. Yeah.
So I say stop share. Right, if you see me here, you can see my finger. If I want to get someone to actually move their DIPJ, in order to exercise it, I can get them to block the PIPJ by putting my index finger over the back and my middle finger, my thumb over the middle phalanx in order to block PIPJ flexion, so I can't move it, and then I can move the DIPJ. It's really clearer there. I mean, it's amazing how much you can actually get people to do, and I would agree with you, Jonathan. I think hand surgery really does. It's actually quite easy to do clinical examination over the telephone, and I think that it's going to change the way we run our practice. I mean, it's not going to change we run my practice because I'm retired now. But I think it will change. Certainly follow-ups. I think it's going to make a huge difference.
Thanks very much.
So there is one last question, maybe two, a question and a point. Someone's asked about testing the passive tenodesis test, which I think now we can see you, Jeremy. I think you could probably demonstrate.
What I want to do, if I do the passive tenodesis test, is basically I want to see my fingers extend when I flex my wrist, and when I extend my wrist, I see my fingers flex. And there's a Smith's tenodesis test to determine whether the central slip of the extensor mechanism is going into the middle phalanx. And if you get your fingers flexed like this and you press down on the finger, you can see there, probably that one. As you press down there, you can see my finger extend even further, and that means that the central slip is intact. So that's one of the ways of detecting whether the central slip is intact. So down here, my fingers are not completely straight, but I'm trying to press the right finger. If I press that finger down, my ring finger, which is what I'm pressing on, actually extends. And I'm not trying to make it extend. That's the central slip acting. So that's the way the tenodesis test works.
And then we've had a couple of points. You've opened a can of worms about the terminology of thumb movement.
Thumb movement. Oh, yeah. I
think it's an attempt.
Can I just say something about this, because I think this is where certain people get on their high horses and decide things which I just don't think is helpful. And although I think the only time I would ever use radial abduction instead of extension is in an exam. And when I say it in an exam, I would say, this is radial abduction, but of course we all call it extension.
I think we're in an international meeting now, aren't we? And I think it probably was an attempt to get some consistency across languages and across international countries. But yeah,
so politically correct. I love it.
But I think palmar abduction is probably the one that's useful, isn't it? Because
palmar abduction, yeah, that movement, palmar abduction, I think is sensible, because that's what's happening. You're actually using your abductor pollicis brevis, so that's sensible. Radial abduction. Yeah.
Okay, so I do apologise. There's a couple more questions, but I think it probably is time to move on to the next talk, which really builds on the importance of examination and moves it into the real arena of assessing the injured hand. It starts with examination, but then carries on with decision making, imaging and decision making. So over to Jonathan.
Thanks very much, Steve. And thank you, Jeremy, for setting the scene. I'll try and endorse what some of the points you made. Whilst it's coming up, there was a question about the, sorry, just get that right, temperature. So start from the beginning. Temperature, and I think temperature, the assessment of the temperature is very much part of feel. So look, feel, move. And testing the temperature to different parts of a normal part of the body, and then testing and comparing between the two sides, and particularly relevant to CRPS. So there you go. I've just answered a quick question. So thanks very much indeed for the invitation to speak. And this really takes the hand examination up to the application. So the assessment of the injured hand. And this is a modification of a talk that I've given at some of the Extensor courses we've done in Malawi. Feedback's been very good. It will be interactive in terms of at the end, but I will ask questions and pause, and then you can basically just acknowledge that you've got it right, but in the interest of time. So the objectives of this talk are to gain a good history of the injury, to assess the clinical anatomy, the look, feel, move, the examination of the injured hand, and the appreciation of the injury itself, the x-rays and when to x-ray, introduction of the 5-point hand injury assessment as initiated by the Derby Hand Unit to appreciate a severity of injury. And then the last two bits was the systematic evaluation. So not just the examination of the hand and the injury, but just to realise what's damaged, what's cut, and what needs to be repaired. And that's the bit which I think is where the trainee has the most, that's a challenging area. And I think you can either do it really, really well, or sometimes in the interest of time, that's sometimes cut short. And then finally, record. We live in a world where there is much litigation, and I understand that litigation is becoming quite a big thing in the developing world. So we need to record our findings. So we'll start off with the assessment of the injured patient. Obviously, in the situation of a polytrauma case, the examination starts with along ATLS principles. A, B, C, D, E. We want a patient who is alive and who is talking and can explain what he's done with his hand. It's life before limb. So the primary survey, followed by the secondary survey with a head-to-toe examination, and the hand assessment comes really at the end of that. And just important just to mention of that. So we get very excited as hand surgeons, but it may not be the most important part of the examination. So we're all enduring the pandemic at the moment, and at the beginning, when all the work sort of kind of stopped, but trauma kept coming in, we wondered whether the hand injuries might go down, the incidence might go down, but in fact they increased. Lots more DIY at home, gardening injuries, and so forth. So the hand surgeon will always be busy. There is lots to do, and it's important to get the mechanism of injury, exactly what happened. You need to know what these tools do and what they look like and how they work. We need to know the difference between an angle grinder and a chainsaw. as it means different things. We thought that sport might tail off, and it did for a while, but now it's back. And unfortunately, England hasn't done very well in the cricket. But cricketing injuries in the hand, very, very common. The bottom left, you'll see a brawl on a rugby pitch, a fight bite, and that's a very important injury to look out for. And then footballing and other things, all very important to get the mechanism of injury when you're looking at the history. Lots of kitchen injuries, lots of people who are doing things they've never done in the kitchen before. So plenty of sliced tendons and nerves to repair. We need to know if there's any contamination of an injury. So if you've been bitten by a pig and it's in a grotty stable area or a pigsty, then you need to know about contamination, the risk of infection. And in the bottom right, you see a picture of a British lion. And a bite from a cat can be quite a serious injury in a hand and lead to serious infection, a flexure sheath infection. And then you've got the potential of a crush injury. So find out the timing of the injury, exactly what happened, and the environment, and also the usual past medical history and whether the patient has any immune impairment and whether they have any other problems with their general health, whether they're on warfarin, all that kind of thing. So we come to the injured hand, and there we have, there's a slice on the finger, and we're going to look at it and see what to do. At this point, worth mentioning that, and it's when you examine a hand, is that you may well need to put some local anaesthetic in early on so that you can actually examine the hand. Very important before you put the local anaesthetic in is to assess the sensation and then put the local anaesthetic in, but certainly have a low threshold for putting a local anaesthetic in to minimize, to reduce the pain and allow you to do the look, what Jeremy was saying, time to look at the hand. Sorry about the phone call in the background. When we look at this hand, we see a cut in the finger, but how many structures are damaged? There's the skin, and literally about a centimetre beneath that, you've got bone. So you've got lots of different structures, and it's very difficult to know whether this is a severe injury or a very mild injury, which really just needs a few steri-strips on it. So first question to you all is, what structures do you think might be damaged in a laceration to the index finger? I'm going to give you 5 seconds just to think about that. And then I'm going to tell you what I think in terms of what I see. So I see a laceration over the index finger, which is going to the radial side. I know that the digital nerve on the radial border of the index finger is more superficial than the ulnar side, and that the chances of a digital nerve injury are high. I also think that the finger is slightly extended, and I think that the flexor tendon may be damaged. So that's at least an FDS, possibly an FDP. I think the ulnar nerve, digital nerve will probably be okay. So that's at least an hour and a half's operating and possibly a requirement for a microscope. Anyway, good pat on the back for those of you who got that. I'm now going to just tell you about the 5-point hand injury assessment. So this really just goes from superficial to deep. Skin, vessels, tendons, nerves, and bone. And that's really going down to the bone. So there are 5 structures there. The next question is, which is the most important structure of those 5 things? So 5 seconds there. Which is the most important of these? Skin, vessels, tendons, nerves, and bone. Well, you're absolutely right. The vessels are the most important. If the finger is not viable, there's no blood supply, then there's no point in doing any complicated repairs. But if you appreciate that those 5 things, if they're all damaged, then you effectively have a grade 5 injury, and it goes from mild, where you have one of those structures, and you have 5, and that means that there's a severity injury. And now, although that seems very, very simple, it just gives you some idea of trying to sort out which are the mild injuries and which are the severe injuries. So keep that in mind as we go through. A quick reminder on the flexor tendon zones of injury. And this is because we have to record these, and we also have to plan our surgery. So going from the end, we have the zone 1. I'm sure all of you will be thinking this through as I do this. I appreciate this might be second nature to many of you. Zone 2 runs from the insertion of the FDS to the end of the beginning of the A1 pulley. So that's zone 1, that's zone 2, and then zone 3 runs from the A1 pulley start of to the end of the carpal tunnel. And then zone 4 is the carpal tunnel, and then zone 5 is proximal to that. So moving on to a clinical case, please have a look at this and see what structures you think may be damaged here. A laceration of the volar distal forearm. Give you 5 seconds to think about what structures might be damaged here, and whether you think this is a severe injury or a mild injury. So it is obviously a severe injury, and the structures that I'm thinking of straight away here are number 1, palmaris longus, and with that goes another very important structure, or more important structure, is the median nerve. So this is a median nerve injury, 100% division. And then the other structure is an FCR tendon, possibly radial artery. I think the ulnar structures will probably be okay. Do you see how that this might seem as though it's quite, well, reasonably superficial, but until you actually evaluate it and systematically evaluate it, you find out there's other structures inside. You will always find more than you think. So local anesthetic and a systematic evaluation is a good idea. I'm going to quickly show you the extensor tendon zones just for completion. The extensor tendons, they're relatively straightforward. It's very in terms of you've got more numbers, but it goes from 1 to 7 or 1 to 8. Number 1 goes with the joints, so it goes with the joints. Number 1 is the DIPJ. Number 3 is the PIPJ. Number 5 is the MCPJ. So zone 1 is at that point there. Zone 2 and so forth down to the distal forearm. So important to know the extensor tendons. So let's look at another case. This actually looks quite simple, quite straightforward. There's just a few lacerations, a little bit on the index finger there, something on the middle finger, and then this area here. So what zones are we talking about here? So looking at the index finger, I can hear you say zone 3. And then this one again is zone 3. This is actually an open central slip injury. This was the worst injury in here, and that needed to be properly evaluated and not just sutured and needed to be extended. What zone of injury is here? Extensor tendon zone, that's 1, that's 2, that's 3, that's 4. So this will be, that's 5 MCP joints. So this is zone 6, extensor tendon injury. And that had divided through the EDC. So the difference between this injury and the previous one is these are small little lacerations, puncture wounds in the hand. And the last one on the volar wrist with the median nerve injury was a very large 5 centimeter gash on the wrist. So one seemed to be very obvious, the others not so obvious. So the size of the skin wound may not be proportional to the amount of structures damaged. So I don't know if any of you have seen this chap, but many of you, you might have seen him, Sherlock Holmes. He's a famous British detective. And in fact, the Sherlock Holmes book was written by a doctor called Arthur Conan Doyle. And he explained about the science of deduction. And this ties in with what Jeremy was saying about looking. Because if you look very carefully, then you can deduce things and then you can find things out. So we'll do a little bit more deducing in the rest of this talk. So we're going for careful evaluation on this. Can anyone see what is wrong with this case here? In fact, if I'll just move the, yeah. So if you look very carefully, you can see that the little finger's flexed, and then just at the proximal wrist crease, there's a small little scar. And then if you look more carefully, you might see that the hypothenar eminence is a little wasted. So in fact, this is a damage to the ulnar nerve, and you've got ulnar hypothenar wasting, and actually a clawing of the little finger. It's not actually a true clawing because the hyperextension of the MCP is not there, but this is, look very carefully for scars. Scars, sinuses, and swellings, that goes together in your normal clinical exam. You've seen this slide before, sensory innervation, and that normally is fairly standard. This is on the palmar side. Median nerve on the palmar, 3.5 digits. And as Jeremy was saying, the radial nerve innervation does come round on the thumb. So if we're looking for the autonomous zone of the median nerve, we always use the index finger. And for the autonomous zone for the ulnar nerve, we use the little finger. And then for the radial nerve, you go over the anatomical snuff box. And these should be part of any clinical evaluation you do. You should record, it's not just no neurovascular deficit. It's sensory for the radial nerve, sensory for the median nerve, sensory for the ulnar nerve. And there should be 3 ticks on those 3. And then you should always do a motor nerve for each, a motor innervation for those, so a muscle for each of those. And for the median nerve, it's abductor pollicis brevis. For the radial nerve, it'll be thumb extension. And for the ulnar nerve, it's usually the abductor digiti minimi, or you can use the first dorsal interosseous muscle. I'm trying to put it in front of the camera there. I'll just throw that in for good measure. So this really overlaps and just confirms what we were talking earlier on. That previous slide, there's a laceration over the ulnar nerve, there's some numbness over the ulnar 1.5 digits, and a claw. Science of deduction, ulnar nerve lesion. I think you've seen something very similar to this before, but this is probably a little bit more subtle. Can we see the wasting here? We're looking for hills and hollows in the hand. And you can see here that there's a fullness on this side, which is the first dorsal interosseous muscle. It's a beefy muscle. You know when it's working and you can resist it and show it, demonstrate it. But on this side, you've got a hollow. So the first dorsal interosseous muscle is not working. So that again is another sign of an ulnar nerve lesion. So which patients do we x-ray? How do we decide what to x-ray? Well, depending on the force involved, kinetic energy, mass and velocity squared divided by 2. If you know it's a high energy injury, you're gonna do an x-ray. If someone's fallen off a horse and they've fallen onto their wrist and they've got a scaphoid fracture, you need to x-ray them. If they've got localized bony tenderness, you're going to x-ray them. Have a low threshold to x-ray. And in fact, I'd add to that in terms of the fingers, when someone comes in, they've got a swollen finger and a bruised finger and they say, but I can move it, I would still x-ray it, because we don't have x-ray spectacles. We have to look at it. And if you get pain on moving the joint. So have a look at this picture. We'll quickly rehearse your flexor tendon zones. So on the thumb, this will be a zone 1. And then here, looks like it's just proximal to the insertion of FDS. So that would mean that would be a zone 2. So that's no man's land. Got to be careful there. And please note that the skin laceration, they look like some necrotic edges. This is a barbed wire laceration. So this is going to need debridement. There's going to be a risk of infection here. Now we're going to get progressively more complicated and a little bit more sort of, if you like, slightly more sinister as we go through the talk. Can we notice anything here that might be slightly concerning? So we've got what looks like a stellate laceration over the middle finger, the long finger as the Americans call it. But as you can see, there's some duskiness in the tip here. And so this is a vessel injury and a viability problem. So this needs to go to theatre in a timely fashion. The zone of injury for this ring finger, is this a 1 or 2 or a 3? So 1, looking like a 2, isn't it? And so that is a flexor tendon injury until proven otherwise. But this is the priority. The fingertip is non-viable and this needs to be sorted out. What do you think the diagnosis is here? What can you see? Put your looking glass on. Be a Sherlock Holmes. We're looking at this thumb. I think you're all agreeing. You can see some redness here, some swelling. There's the loss of those of the skin creases. So something's afoot. And there's also some disruption of the nail. There's also some blood under the nail. And that's an indication to remove that and sort that out. And as you can see, that's a good going nail bed injury. Nail bed injuries, they're an innocuous, seemingly innocuous injury, but they can cause problems and they can cause infection because this is an open fracture. So if this gets infected, then you've got a problem. And one of the World Health Organization targets is to improve the treatment of open fractures in the world globally. So we need to treat nail bed injuries. I know, yes, they do heal up well, but they need timely treatment at the beginning, debridement, and then closure. You don't necessarily have to replace the nail, and there's studies going on to looking at that was whether you have to put the nail as a cover. The most important thing is to debride the wound. Now, this is an unusual injury, but involves someone who is married or wears a ring on their finger, and they've got it caught. So this is a particular, a very severe pattern of injury, which leads to an avulsion. And this is the result of that injury in terms of the avulsion of the skin cuticle, but with the structures and the fascia between the skin and the extensor peritoneum. So there is a risk of viability to the finger, and this needs to be evaluated carefully. And the history is so important here. And there is a classification which you should all look up, the Urbaniak classification, and this will be the highest grade. So moving on now to more severe injuries, and this will be one of our case discussions later on. And I think it introduces the concept of finger-threatening injuries, and as to whether you need to consider amputation. This looks as like I said, partial amputation or almost complete amputation. And I think the tendency will be for us is to say, well, I think that's the end of that finger. We'll just tidy that up and close it back. But in fact, if you look carefully at the finger, the nail bed is still pink, and the blood supply is still okay to the tip of the finger. So at least one pedicle is still intact. So keep that in mind, is that we don't necessarily need to, we need to reduce this finger and put it back into a normal position and then see if the blood supply improves. But it's a grade 5 injury involving skin, tendon, bone, nerve, and therefore that all needs to be evaluated. But we'll keep the discussion exactly on the management of that for later on. So the first principles, when you see something that's dislocated or malreduced or bent, if you like, then you need to reduce it. Just like an ankle that's facing the wrong way, the first thing to do, put some local anesthetic and reduce the finger. And as soon as you do that, you restore the blood supply. The blood supply in the finger is very, very good. It's quite hard to devascularize a finger. And normally, even if there's just one pedicle, is enough. So this brings us on to towards the end of the talk, but it basically, in terms of the scoring systems for whether to amputate or to save a finger, salvage a finger. And there are a number of scores available for this. There's the hand injury severity score. There's also the mangled extremity severity score. But I think we can get rather hooked up on looking at these and saying, well, does that hand match that one? Does that finger match that one? Oh, I think we better have a discussion about amputating the finger. But I think they're not particularly helpful in the clinical situation. I think you have to look at each case on its own merits. And the take-home message, is to lean heavily towards initial salvage. You can always go back and do something at the 48-hour stage. The propensity of the fingertip or tissues in the hand with its wonderful blood supply to recover, and options for reconstruction later. And this is why the area of hand surgery with its orthoplastic interface is really useful, and always keep the options for a reconstructive procedure at a later date. That's not saying that every case should be reconstructed. It's quite clear when a timely amputation, depending on some person's circumstances, they're keen to get back to work, and there's obviously depending on the pattern of the injury. But bear in mind that always just consider what potential reconstructive options there are, and to come back at 48 hours later and make your decision at that point. So that's a point I'd wanted to labour really a little bit. Jeremy was talking about the natural cascade of the hand and the lining up of the tips of the finger in a very, very distinct pattern towards going from the index finger to the little finger across the hand. So and this really demonstrates the tenodesis, leads us into the tenodesis test, which was mentioned early on. The reason why the tenodesis test works is because the tendons are long tendons. They cross all those joints. And so all you have to do is to move the wrist joint, and then the fingers will flex and extend completely passively. And it's something that we probably do as hand surgeons every day. It's not just in a clinical examination for medical students or in college exams. We do it at the start of a flexor tendon repair. We do it at the end of a flexor tendon repair, and we do it in the hand clinic maybe 15 times. So I want you all just to demonstrate and do it as, in fact, it's probably easy for you to have one of you, if you do it with your one hand, so you flex your wrist and you can see your fingers extending. So you do it passively. So try and switch off your nerves in your right hand and then just passively move that wrist. So and then just try and do that. And I want you to do this whenever you have an idle moment today, and just try and see how those tendons move, because this will allow you to assess the integrity of the extensor tendons and the flexor tendons. And the beauty of it is when you assess an injured hand is you don't even have to touch the hand at all. You just need to say, I just want to borrow your hand. I'm not going to touch your injury. I'm just going to move your hand and see if those tendons, and if those cascade is broken, then you know that there's a tendon injury. So it's probably one of the most useful tests in assessing a tendon injury. So there's the tenodesis test. And I think it's worth emphasizing that. And here we have a loss of the cascade. You can see that the index finger is fully extended, and there is a laceration in the at the volar aspect of the wrist, just by the distal wrist crease. So which tendon may be damaged there? So the tendons to the index finger, the flexor tendon, the FDP and the FDS tendons probably. But we also know that it's quite likely that there may be partial injury to the flexor tendons for the other fingers, but the cascade appears to be normal, but that needs to be explored. Here we've got a loss of the cascade. Does anybody know what the diagnosis is here? There's some bruising in the ring finger. You can see there's some bruising there. There's a loss of the cascade. We know that that's probably a flexor tendon injury. So which tendon would that be? Because that would probably be FDP. There's a history of this person playing rugby and pulling on a jersey while someone was trying to get away. So that's why it's actually called a jersey finger, because it's an FDP avulsion. And here you can see on the X-ray, there's a flake of bone here, which is attached to the FDP tendon. And this has actually traveled all the way from the end. So it's pulled off from here and it's gone all the way to the end and down, and it's got caught at the A3 pulley, basically by the PIP joint. So this is the Ledian Packer classification, and this particular one is a 2 because it's actually got caught at the PIP joint. So we're just moving on to some simple things that when you've actually done your assessment, you've done your tendon examinations, you've put local anesthetic in and so forth, there are things that you can do whilst you're assessing the patient. In other words, there's like a see and treat type thing. So we're going into a bit of management here, but if you've got a finger that's bent, then put it straight. This is a children's finger. And then one of the comments from the delegates earlier was how do you examine a child? I mean, the thing about examining a child is just you get their confidence and sit down with them and just chat to them for a bit and make them feel comfortable. And then otherwise, it's very similar to an adult examination. It's just making the child feel happy and relaxed that you're not going to hurt them, and just reassure them. With this one, it's probably worth putting some local anesthetic in, and this is a Salter-Harris 2 type fracture. And the way you can reduce this is to use the pencil trick. So therefore, you just align it with a quick click and then put a little splint on, and then effectively you've seen and treated the patient. You've assessed them. So the final part of the hand assessment is to make sure that you assess the rotation of the finger. So this finger looks almost right, but perhaps there's a hint that there may be something not quite right. It's quite swollen. The ring finger's quite swollen. And then when we ask them to flex their finger, you can see that that finger is very rotated. So the message here is make sure when you're looking at rotation, get the finger straight and then assess the rotation in the various positions and compare them with the other side. And you can do that literally by holding your hands out there and saying, now just show me that, and just keep watching the fingers and seeing the comparison on the other side. And you might need to put some local anesthetic in this to help allow the examination so it doesn't hurt. Moving a little bit onto X-ray, but Subodh will talk more about the X-rays on the next talk. Really important to look at the 2 views. So we've got a PIP joint hyperextension injury. Let's look at the lateral. And hey presto, we have a dorsal dislocation. This is a bony vodoplator injury with a dorsal dislocation. So we could probably treat this in the clinic and probably treat this as it is. So let's see if we can do a see and treat for that. There's the position of the PIPJ. The middle phalanx is dislocated dorsally. There's the fracture. And this can be treated quite simply with local anesthetic, a digital nerve block, and putting a dorsal block splint on. So that's best done right at the beginning. And that's a good way of doing that. And then in a similar way, a bony mallet injury, and these are quite a troublesome injury. And you have to be very careful because these can sometimes sublux 2 to 3 weeks down the line. There you've got the mallet injury, there you've got the bony, you need to reduce it and then apply a mallet finger splint. You may need to operate on these if the joint is not reduced. So always take an X-ray after you've put the mallet splint on. And if the joint isn't reduced, then you need to put a wire down the joint. So there's a few options for mallet splints. Splint is all about compliance. And there will be further talks on splinting and rehabilitation in future webinars on this. So I'm going to draw to a close in the next minute or so. This is one of the last questions. Does anybody know what this diagnosis is? You can see that there is a change in the contour of the ulnar collateral, the ulnar condyle, and there is an avulsion fracture of the ulnar collateral ligament. So this is an acute skier's thumb, and this needs operative treatment. Okay, so the last case I'm going to show you is one where it really ties it all together because we're looking at this X-ray, and the X-ray actually tells us the severity of the injury. The X-ray shows that there's not just a fracture, but there is actually a soft tissue injury that goes through most of the finger. So this is making us the point of that a fracture is a soft tissue injury complicated by a break in the bone. And so if we actually see the injury itself, we can see that this is a finger-threatening injury. It's not a replant situation, but it's one that you need to see quickly and to assess. And when we talk about replant situations, there's a window of opportunity to replant a finger. And it's very important that you get the amputated part and put it into a plastic bag, and then you put that inside another plastic bag with the ice so that you actually preserve the tissue, and you don't you give the chance for the tissue to survive for it to be replanted. If there's facilities nearby where you can offer a microvascular repair. And so be aware of the situation when you've got a finger that's so badly damaged that you're talking about a replant or revascularization. And that again will be addressed in future webinars on that sort of more advanced surgery. So in summary, this is really emphasizing the 5-point hand injury assessment method: skin, vessels, in capital letters, tendons, nerves, and bone. And that innocuous skin lacerations and puncture wounds, that they might actually be a more severe injury than you previously appreciated. There will be a summary sheet handed out for this, which we will send by email to all of you, and that it'll be a nice aid memoir for you to keep a look on that. So we've looked at the importance of getting a good history, knowing the anatomy, the surface anatomy, which is all there to feel, the examination of the injured hand, when to X-ray, the 5-point hand injury assessment, and the importance of systematic evaluation. What is damaged here, and what do I need to do at this stage? And finally, to record with a picture if possible, and the integrity of the tendons and the sensation and the muscle power. And that should have your signature on, and that should be, you should have some pride in your recording of an assessment of the hand, because it will lead to more timely intervention, better outcomes, and also much better for the patient. So thank you very much for listening. I'm sorry about the overlap with the hand examination talk, but I'm told that an educational tool is to repeat a little bit and take you further forward. So I'll pass you back to Steve for the rest of the program.
Well,
Happy to
thank
take
you
any
for that,
questions.
Jonathan, that was excellent. So we've got a couple of minutes for people to post questions for Jonathan. There will be another opportunity to revisit this in the case discussions, but if you've got any urgent questions, please do post them in either the chat function or the Q&A function. I'll do my best to read them. So someone's asking about how would you repair that ulnar collateral ligament injury that you showed, that bony avulsion fragment.
So with the bony fragment, they're normally just too small to put a screw in, but sometimes they will take a very small 1.2 millimeter screw. But I tend to have a low threshold for putting an anchor suture in just distal to the footprint of where that ligament is. And it's you effectively do the incision through a lazy S incision over the ulnar collateral ligament, explore carefully, mobilize the fragment and the ligament, and then anchor it. It's normally a pull-off distally, so you'd put an anchor in, and then you'd suture the ligament into place there, and that normally brings the fragment into line. I think the option to put thread sutures through and bring them out dorsally, I think that is an option, but I think that can cause complications with infection and widen the area of the problem. And I think this works extremely well. Put it into a cast afterwards and works nicely. So these anchor sutures now with the advancements are absolutely wonderful use.
Yeah, we've got a question about the time frame for replantation.
Well, the time frame for replantation, I mean, that does depend on the environment you're at and also the distance to travel and so forth. But you've got cold ischemia time or warm ischemia time. But really, you've got to get it. I mean, the absolute latest time would be within 6 hours. But normally, you're looking for the golden hour, aren't you? So you need to move fast, really. There are other factors in terms of age of the patient, comorbidities, and so forth. And the degree of contamination of the amputated part. No, I think that this is certainly a topic which will be discussed in more detail in one of the revascularization and microvascular webinars probably during the year. Discuss it with your local referral centre. Always keep the implant, the amputated part, put it into ice, record, take pictures, WhatsApp them, whatever you do. Speak to the local hand centre and say, is this an option? What level is it? We've certainly amputated more fingers during COVID because of resources and access to care. But now I think it's worth keeping it in mind, particularly if it's more proximal. Certainly, middle phalanx and proximal. It's worth keeping it and phoning for advice and seeing if you can do it, or even get them in the car and get them heading towards the centre. 1 to 2 hours.
Don't put it straight into ice, though, please. The amputated bit, not straight into ice. Otherwise, you'll freeze it and kill it.
Yes. Yeah,
so you put it in a plastic bag, and you put that plastic bag in another plastic bag that's got ice and water in it.
Absolutely.
We've got a couple of questions that getting onto management, and probably I would encourage people to join the talk on the mutilated hand on the 23rd of April. A question about electric burns injury to the hand, the order of reconstruction vessels first, clearly to restore viability, but I think they will be covered in the mutilated hands section. There's always a risk here today that we will get drawn very much into the actual management of these injuries, but they will come later in the program, the management.
Steve, I've just seen a question on management of snake bites, and I think actually that's the sort of case that would be really good to get someone speaking from an area where there are lots of snake bites, and they've got certainly in Malawi, I know there's a lot of snake bites, and I've seen some papers presented on snake bites there. It'd be great to have the expertise and the experience of someone who's seen a lot of snake bites. So I think this is about a knowledge sharing exercise. Because we don't see many snake bites in the UK.
No, well, I have not seen any, and I think there are 3 native snakes that are native to the United Kingdom, none of which are poisonous. So we're very fortunate.
If anybody would like to give a talk on snake bites in the delegate group, then please do email us, and we might be able to include you in a future webinar. Yeah,
got a question about rehab after tendon repair, and this is really unusual, this session for a BSSH hand surgery webinar, in that we haven't got a therapist present. We almost always do, and certainly in the UK you are not a proper hand surgeon unless you've got a good therapist working with you. But next week is the tendon repair, and that will definitely be covered in that webinar next Friday. So I think that in order to allow time for the rest of the webinar, I think we should move on. The previous 2 talks are equally applicable whatever environment you are working as a surgeon. We are very conscious that in the United Kingdom we are very fortunate with our resources, which includes access to imaging as well as access to surgical implants and facilities. But clearly part of the assessment of the injured hand is imaging. So if I can hand over to Subodh to explain how we do imaging, particularly in the UK.
Yeah, thank you very much, Stephen. My talk is on hand imaging, so I'm not going to include any electrical or nerve conduction study type of investigation, just simple imaging studies. So I work in Birmingham Royal Orthopedic Hospital. I do a little bit of engineering work in the local universities, Aston as well as Birmingham. So I have got sort of 2 prongs to my clinical practice, a bit of engineering as well as clinical work. So let's start off with the imaging lecture. I mean, I'm sure you will know that there are different type of imaging available now. Increasingly, more imaging studies are used more and more in hands examinations and preoperative investigations, postoperative investigations. But
sorry to interrupt. Do you want to just put your screen on full? Then okay,
just a minute.
Thank you. Sorry about that.
Is that okay?
Much better.
Yeah, okay, thank you. Yeah. So we obviously use plain X-rays, the maximum, and obviously we also use scans, ultrasound, CPs, MRIs, and other things. So let's start off with simple plain X-rays, how they are useful in evaluating hand injuries. Obviously, as Jonathan and Jeremy have said, your clinical examination is absolutely vital. I think trying to make a diagnosis using scans and X-rays is dangerous. I think your clinical examination is absolutely important. Your history is also equally important. So once you have that sorted, then you can look into investigations. So if you look at simple plain X-rays, the standard X-rays for a hand and a wrist would be an AP, oblique, and lateral views. Certainly for the hand, AP, oblique, and lateral views are absolutely mandatory. And when it go into the wrist, a simple AP and lateral view would be enough. But if you want to diagnose a little bit more complicated carpal instabilities, then gripping views are useful. These are more useful in a more elective situation. When there's severe pain, these gripping views are not very useful. An ulnar deviation view is useful if you want to look at scaphoid fractures, and there are different scaphoid views available which can pick up scaphoid fractures. Typically for a first CMC joint visualization, GEDA views are useful, and I'll show you a picture of what a GEDA view would look like. And it is a very useful tool in diagnosing CMC joint dislocations and fractures. A carpal tunnel view can be used to look at fractures of the hook of the hamate in absence of CT scans. It's a difficult view to actually get through. The radiographer really needs to know what they're doing. But once you get a good view, then you can actually diagnose fractures of the hook of the hamate using this view. So here is a picture which shows the AP oblique as well as the lateral view of the hand. And I think these three views are absolutely mandatory, especially if you're looking for CMC dislocations of the fourth and the fifth CMC joints. I think a lateral view, a true lateral view, is very useful. And it's nice to have fingers in different positions. For example, if you look at a finger, the lateral view, you should always try to keep the fingers in different position, not in the same position. Otherwise, if you can miss out fractures in the fingers. Oblique views are also useful because you can see metacarpal fractures better rather than a true lateral view. What these views are not good at is picking up rotational malalignment or rotationally malaligned fractures, and that requires good clinical evaluation rather than X-ray evaluation. Here's a simple AP view which shows the dislocation of the fourth and the fifth carpometacarpal joints. And if you look at this X-ray, what it shows is that if you draw a line along the fourth and the fifth metacarpals, these lines do not meet the other two metacarpals. And these are parallel lines, and that they indicate that the fourth and the fifth are dislocated. If you take a lateral view, a true lateral view, you would also see that these joints are dislocated. But this is also a very good clinical radiological sign to pick up dislocations of the fourth and the fifth CMC. Now, this is the GEDA view which I was talking about. It's a very useful view, a fairly easy view to take, and you can pick up fractures of the base of the first metacarpal. You can look at or pick up subtle subluxations. You can look at loose bodies if there are any in the first CMC joint, and other abnormalities of the first CMC joint. Once you have fixed a CMC joint or a CMC joint dislocation, if you have done it correctly, a good GEDA view can tell you whether the CMC joint has been accurately reduced or not. A simple AP and lateral view may not be able to tell you accurate reduction. This is what the carpal tunnel view looks like. So this is the way the hand has to be dorsiflex substantially. The X-ray beam has to be angulated by about 25-30 degrees proximally. And then you can see the hook of the hamate here. And if there's a fracture at the base of the hook of the hamate, that can be picked up. This is the gripping view or the AP gripping view. And if there is a dynamic scapholunate instability, you can see the scaphoid and the lunate separate and the capitate migrates proximally. If you let the grip off, then you might find that the scaphoid and the lunate come together. So these dynamic views are also useful, but as I said to you before, they are only useful in the more elective situation rather than the acute situation, because when there is significant pain, it's very difficult to do a gripping view. Let's talk a little bit on scaphoid views. I think these are commonly used views to pick up fractures of the scaphoid. So there's a PA view, there's a lateral view, there's a PA with ulnar deviation, and a semi-pronated oblique view. There are the four views. You can add a fifth and a sixth view as well, but four views are quite standard. You can do a PA with radial deviation, and you can do a semi-pronated oblique view in a 180-degree rotated hand as well. So that improves the sensitivity. But most people will accept that the overall sensitivity of scaphoid views to pick up scaphoid fractures about 80 to 85%. So there is still a significant 15 to 20% fractures which you miss when you do simple scaphoid views. And even if you do the same views after 10 days, there will still be a certain proportion, I would say about 10%, you would still miss if you do a similar views after 10 days of injury. So these views have their limitations, but I think they are quite useful in the primary care setting or in an A&E setting. But once the patient is referred to a hand surgeon, then other investigations may have to be done to pick up subtle fractures of the scaphoid. Ultrasound scan, they are increasingly used in hand surgery. It is highly operator dependent. So you really need a good ultrasonologist who can do these ultrasound scans. But once you've got a good ultrasonologist, you can quickly differentiate between cystic and solid tumors. You can do dynamic screening. So the patient is moving his hand or moving his fingers, and you can pick up subtle abnormalities like triggering partial ruptures of the tendon and carpal instabilities. You can look at synovites of the tendon sheath. And if the ultrasonologist is also sort of a clinician who is keen on doing procedures, you can do injections as well. Ultrasound guided injections are quite useful and commonly used in the UK at the moment. You can even aspirate ganglions if you wanted, small ganglions, and you can inject trigger fingers using an ultrasound scan and direct your needles in the right position. CT scans are not commonly used, but they are more useful in the acute situation where you have fractures which you want to evaluate a bit further, typically avulsion fractures, to see where they are coming from. Scaphoid fractures are obviously evaluated much better with CT scan, and there's always a debate which is better, a CT scan or an MRI scan. I think the debate is more or less solved that the MRI scan probably has got a higher sensitivity and a higher specificity compared to a CT scan, because you can sometimes miss subtle fractures if the cuts don't go to the fracture. So I think in most situations now you go for a MRI scan, but if MRI is not available and you're still suspecting a scaphoid fracture, a CT scan is probably quite useful. Certainly for hook of hamate fracture is a very, very useful tool, and most hook of the hamate fractures can be easily diagnosed based on a CT scan. If you are going to operate distal radius fractures, then I think is another almost a mandatory tool nowadays in the current setting, especially if it is a intra-articular fracture, and preoperative planning is much better if you have a CT scan, and especially if you've got a 3D reconstruction. And you can see there's a picture on your right side which shows what a 3D reconstruction looks like, and a preoperative planning certainly is much easier if you have a 3D reconstruction. And certainly if you're going to do post-traumatic reconstruction like osteotomies, I think 3D reconstruction are becoming quite useful and almost mandatory in the UK. Here's another picture of a CT scan of a intra-articular distal radius fracture, and you can see how a CT scan can show much more than a simple X-ray, and you can see the nature of the fracture. The worry always is that the CT scan shows the picture to be a lot worse than what a plain X-ray looks like, and sometimes frighten you. But I think most senior clinicians can pick up the problems quite comfortably. And the new kid on the block is to do a 3D reconstruction and then print using a 3D printer. So that if you got good you got trainees, then you can actually look at these images and you can also handle the fracture, and you can see where you want to put your screws and your plates. So these 3D printed images on the bottom two pictures are also quite useful. Our hospital has just recently acquired a 3D printer. So these are quite useful for, I won't say sort of a play tool, but I think it's going to be more and more useful in the clinical scenario. Coming to the MRI scans, obviously these are gold standards now for subtle fractures, shear fractures, scaphoid fractures. But the problem with the MRI scan is that it can pick up things which you'll never see on an X-ray or a plain or a CT scan. Typically bone edema. And bone edema can confuse a clinician and a radiologist. And you really don't know, is this a clean-cut fracture or just an impression fracture? So bone edema is a little bit more sort of something which you need to be aware of. But MRIs are wonderful at diagnosing synovitis, subtle ganglions, intra-articular ganglions or intraosseous ganglions, GCTs, tendon ruptures, ligament ruptures, and even carpal instability. So if you got a scapholunate ligament rupture, an MRI will certainly pick it up. The problem is that MRI can't pick up all abnormalities. Typically, if you got a mid-carpal instability or a subtle ligament instability, it might not pick up. So your clinical examination and your clinical history has to be correlated with the scan at that stage. Here's an MRI scan of a finger which shows a chronic tendon rupture. You can see that there is a gap in the FDP tendon distal to the middle phalanx, and you can see there's an increased amount of fluid in that area. If you look at the picture on the right side, the picture on the right side shows a clear-cut scapholunate dissociation. There isn't an increased gap in the scaphoid and the lunate, but there's certainly a rupture of the scapholunate ligament, and that probably will not be picked up on a plain X-ray. You would see that the plain X-ray probably is entirely normal, but an MRI scan will pick it up. And last but not the least is an MRI arthrogram. And these are useful if you got abnormalities of the TFCC and certain ligaments. I wouldn't suggest that this is a useful tool for most ligamentous injuries. Typically, TFCC tears are better diagnosed using an MRI arthrogram. You can also make diagnosis of scapholunate ligament injuries using MRI arthrogram. I have not talked about bone scans because bone scans have really fallen behind, and I probably don't use bone scans as much as what I used to do, say 20, 25 years ago. I think the only indication for a bone scan at the moment is if you are suspecting an osteoma in a phalanx, then I suspect a bone scan might be useful. But even though those will be picked up with an MRI scan. So bone scans really are not very useful nowadays. In the past, bone scans were used to diagnose chronic regional pain syndrome and increased uptake in the bones and the soft tissues. But again, the clinical examination and the clinical signs are much more useful than a positive bone scan. So bone scans really are not being used at the moment. So what is important is that you need to understand that trying to do investigations before you make a good take a good clinical history and a good clinical examination can be dangerous, because you can see abnormalities in MRI scans which you may not be able to then correlate with your clinical history. So detailed history, detailed examination, making a good differential diagnosis, and then advising investigations is probably the right way of doing it. There are junior surgeons who want to investigate first and then make a diagnosis, and I think that's a terrible thing to do, because you can really go the wrong way. So I think you need to be careful there. Thank you. Any questions?
Questions for Subodh? Just time for one or two. Oh, well, could I ask Emma to load the cases then, and we've got 20 minutes to go before our scheduled finish time, so we have got a few clinical cases that we'll use the panel to bring out some of the points that in all three talks really. So if next slide please, Emma. So this is the first case. And there's some clues in the history. This is a 60-year-old male patient with a fresh chainsaw injury. In the UK, chainsaws are used to cut down trees. They're very powerful devices, and they do a lot of damage. So I don't know, Jonathan, do you want to start us off with just or even Jeremy, actually, what would you do from an examination perspective on that? And
well, I'm looking at it, and I'm looking at it, the skin. So we start off with Jonathan, the skin to start off with, and the skin is macerated. And if the skin is macerated, it's very likely the tissues underneath are going to be macerated. The fact that we've got an extended little finger and a lack of extension of the middle ring and index would indicate to me there probably is a tendon injury, and that's going to be right over the central slip. Now, the central slip is one of the few, if it's an open injury, that's the few times that I would ever explore and repair a central slip. But you've got to be very prepared that that central slip is going to be as macerated as the skin, so it's going to be difficult. So we know there's a skin injury, we know there's a tendon injury. Looking at this, we're going to have obviously a venous injury from the back of the fingers, but not necessarily vessel injuries, and the vascularity of the digits distally are absolutely fine. So we're not sort of worried about the vascularity of it per se. Obviously, we've got a condylar fracture of the proximal phalanx of the index finger, which is completely dislocated, and that will need to be put back. So assessment of it, essentially vascularly it's all right, it doesn't need to go to theatre straight away, it's an open compound injury, therefore I would still take this, despite the fact there are recommendations otherwise. I would still try and get this to theatre before 6 hours, and it needs a thorough debride and an exploration, and I would repair the tendons, and I would probably try and stick that condyle back and try and fix it with something, but I would probably, it's a very small fragment, and I would probably only use K-wires, and appreciating the fact that if it is K-wires, you're not going to get a huge amount of stability of that fracture, but you'll get you should get it back to a better situation than it is now.
yeah,
sorry.
Yeah, that's very helpful. Jonathan?
Jeremy, I'd agree entirely.
What have I missed, Jonathan?
No, you haven't. You've missed. No, you've missed nothing. And absolutely right. I completely agree with that. But what would worry me is, number one, as you said, central slip, and the rehab afterwards. So a timely debridement and a reduction of the fracture and a repair of the central slip. We know that open central slip injuries have bad outcomes. So you've got about 50% chance of it being stiff and infected. They're challenging. So the only thing I'd add to your thing would be to say that whoever does the operation is that they would make sure that there's careful splinting afterwards. So you've got the fingers into extension, and then bring back to the therapist at 1 week, and then a very careful supervised splinting regime, and take the wire out at the right time. So and it's interesting that index finger is the one with the fracture, and so that's the smallest skin injury, and that's where the fracture is. So thank you, very good case. Yeah, agree.
Well, no, it's that. I think it's the one with the condyle missing that's with the biggest wound that's got the fracture. Subodh, would you get any more images?
I think a CT would be great, but if you don't have a CT, my worry is the ring finger, because the condyle is more or less volar, and trying to fish it out from the dorsal side might be tricky. If it is dorsal, it's probably okay, but if it's volar, then you can actually cause a volar arterial injury and actually devascularize the finger, trying to fish that condyle out. So you need to be very, very careful trying to fix that condyle. It's a large piece of bone in the ring finger. Obviously, I agree with Jeremy regarding the central slip injury to the middle finger and the injuries to the index finger and the little finger. I think the ring finger is a bit tricky, because you can make it worse.
Okay, how would we do it? I mean, I would still go through the wound that's dorsal. I'd make it bigger and track it and try and fit it out. I mean, I don't think you wouldn't make a volar incision to get that, would you?
Well, I think
you really had to.
Absolutely, I agree. But I think trying to wiggle it out can cause damage to the nerve or the vessel or both. Yeah. That's the worry.
Yeah.
If they're already damaged.
Yeah. Could I ask Samuel, how would you deal with this injury in Tanzania? Not sure whether Samuel's got Wi-Fi at the moment, but so this was my case, and so I do know a bit more about it. the chainsaw is important because chainsaws don't just cut tissue, they remove tissue. And that can include skin. Going back to Jonathan's slide, I think this is in the middle of, probably 3 tissues damaged, aren't there? There's tendon, bone, stroke joint, and probably some skin loss. And there was a slight skin defect over that middle ring finger PRP joint. I'd agree with Subo. We don't need anything like a CT. We did clearly have a second view, which gave us more information. And I approached this the same way as Jeremy suggested, really. But having warned the patient how badly damaged that PRP joint was. And in fact, there was only one condyle present. I think the other had been flicked out somewhere by the chainsaw. So it was more salvage surgery of that PRP joint, and I did a volar plate arthroplasty rather than a fusion, but having spent quite some time trying to reconstruct the joint surface, it clearly wasn't possible.
Did you do a arthroplasty at the time, acutely, or did you do that at a later
stage? I did, because the volar plate was there and we were in the joint.
Yeah. No, that's a good plan. As Subodh said, was it easy to? How difficult was it to get that bit of bone? Because
it's visible on the photo. Is that bit of bone?
Oh, is it that bit there? Oh, yeah. Right. Yeah. Oh, that's lucky.
Yeah. So I think the main things are the blood supply is intact, the nerve supply is intact, but there's significant injuries to the other 3 types of tissue. As Jeremy says, it's an open joint, so the sooner we get them to theatre and prevent infection, the better. So if we move on to the next case, Emma.
So, Steve, maybe let's start with this one. We could just describe what we see on the pictures.
Yeah.
So looking at the extensor surface, that's a zone, from an extensor zone point of view, 1, 2, 3, 4, 5, 6. Zone 6 extensor tendon injury, potentially. You've got loss of the cascade, so you know that you've at least got an EDC rupture there, a division. And we know that it's a gunshot wound, so we're going to have contamination and a zone of injury. We've got the entry wound and the exit wound. So obviously, whichever way around it is, and whatever type of the weapon that was used, and that's obviously useful to know, high velocity or low velocity. And I know that most things of these days are high velocity. And you've got a palmar wound, and that is the tissues that you'd be concerned about there. Obviously, not just flexed tendon injuries, but also the common digital artery. Perhaps it's just a little bit distal to the palmar arch, but there's a lot of tissue damage here, volar and dorsal. Amazingly, no neurovascular deficit, but obviously careful exploration required. Looking at the X-rays, significant shortening of the metacarpal, the middle metacarpal with contamination, with comminution. So there's going to be an extensor lag, even because of the shortening of the bone, even if that's treated with just a washout and splinting. I suppose the thing to do would be to ask the delegates to comment on how they might manage this, really. Do we have anybody who could say how they would treat this in their unit?
While they're asking that, presumably the entry wound is in the palm because it's smaller, but am I right there or not?
I would, Steve, do you know whether it was front to back?
I don't know, but I would agree with that, and
makes sense.
It suggests it may have been a self-inflicted accidental injury. But again, as Jonathan says, I think the gunshot wound's high energy. It's open. It potentially could involve all 5 tissues, couldn't it? But examination has excluded vessel and nerve.
Zulfiga has just come up with a right spark answer, I think.
Yep, so we've got a suggestion of applying an external fixator, which is always an option with open wounds where we're worried about infection. I think we've got one in the Q&A as well. Someone saying, would this be considered zone 5?
For the flexor? What are you talking about, the extensor?
I presume
Yeah,
they are
nearly 5.
referring to the extensor, yeah.
Yeah, nearly 5. It's 5. It could be borderline 5 and 6. I agree. But in your recording of your injury of the laceration, just proximal to the injury joint, zone 5, oblique 6, extensor tendon injury. And we know when we go into this, when we explore this, there will be other structures damaged. And the main principle for the systematic evaluation here is to expose, do extensile incisions, and that's a topic for another webinar or lecture. Really, is how to extend these wounds. I mean, normally it'd be longitudinal extensions of this, and in the palm you may do some oblique or transverse laceration, depending on which way you want to go, and then making sure that you don't damage any other structures going in. To explore, so blunt dissection, particularly in the palm, so you don't damage the palmar arch, and careful and systematic evaluation. Really, it's one of these cases where you actually do your hand assessment continues in theatre, preferably under regional block, and this could be done under Wallant surgery, and again Wallant, we haven't really touched on Wallant, but this is a very good case for that. But you could do it with the tourniquet and regional anaesthesia, and then you have to decide on how you're going to treat the fracture. But I think an external fixator as a temporizing measure would be reasonable. And at the end of the case, obviously you'd need to go into a proper padded volar plaster with the position of the hand optimized. And this will be another one where the rehabilitation will be a big challenge.
Yeah, so we've got a comment really. Can you please explain the exact best management after discussing? And I think that it's a good case, this, isn't it? Because I think that going back to basic principles, as Jonathan described, really exploring it to see the extent of this soft tissue damage. First, do no harm. Let's try and do our very best to prevent this wound getting infected. And then it will depend upon what is there. We can see from X-rays there a significant bone injury, almost a periarticular fracture, but still with a reasonably intact articular surface. There is quite likely to be a tendon injury, probably more so extensor, I think, than flexor. But that might influence the management. They would need debriding and repairing. The bone, it really depends what resources you have available, I think. External fixation, I think, is a safe way to manage this until you're confident there's no infection. But there's a disadvantage with X-Fix in that, as someone has already commented in the chat room, is stiffness, really. I would only be able to get an external fixator on that in a fair degree of extension, which is probably the worst position to immobilize that MCP joint. I think if I had K-wires available, that is an option to stabilize the bone, but still quite challenging. We're very fortunate in the UK that we have nice plating systems that we could restore length and gain probably enough stability to allow some gentle mobilization of that joint.
You might be able to get hold of that distal fragment with a plate, but I must admit, even though you're going to have the finger in extension, I think the external fixator is the best option here. But you've got to be very careful with external fixators because they can cause all sorts of damage when you put the blasted things in, and you've got to really know where you're where you're putting the pins and making sure you're not putting them in an extensor mechanism. And if you are putting them in an extensor mechanism, you've got to make a big hole for the pins so that they don't snag around the pins and cause infection. So they are difficult. I personally think that that's too comminated to put a plate on. So I think that's what I would go for, I think, initially. Having done really opened it, a real wide open excision and debridement of any dead tissue.
Yeah.
Steve, the only point I'd add to that is that, and the panel and the delegates, is really that I agree with the principles of the treatment offered. I think if this had come in tonight, and the team at Peterborough were looking at this, they would debride the wound, wash it, excise, any devitalized tissue, and then score, evaluate, and put it into a POP volar slab in the position of safe immobilization, elevate, IV antibiotics, and they'd come back to a scheduled hand trauma list probably in the next 2 days. So the first treatment for this, I think this is a 2-stage operation. And I think that would be, again, it just gives you time to think and plan. You can always do your X-fix later or put your wires in later. This is a contaminated wound. So I think it's a 2-stage procedure that's in my opinion.
Yeah, Yuma has asked a very good question, I think, about it, saying, is the tenodesis effect positive there? Is there a break in the tenodesis effect? And absolutely. There is a break in the normal cadence of the hand, which may represent a tendon injury, or it may be secondary to that shortening due to the fracture. But it's a very interesting question. That there's a couple more comments. One of the last one is we would love to have a webinar for fracture management cases, which is a good opportunity really to plug the webinar series where we will be doing hand and wrist fracture management. It's probably about 6 months into that webinar series.
We're doing the wrist fracture webinar in July, so that'll be and then that we'll be able to cover a lot of that there. Sorry, Steve.
We are just about at the end of our scheduled time. I don't think we're going to get automatically cut off, but I'm conscious that it's been a very good attendance. We were at 220 to 230 people logged in for most of the session. It has dropped to just under 180 now. So maybe it's time to draw it to a close. I do really want to take the opportunity to thank all 3 speakers who all gave excellent talks, to thank all the delegates for taking part, for staying with it, and for posting some excellent questions. You will, and then Emma for supporting 4 old men. You will go a career as a carer in the future. You'll be well suited for that. Definitely a plug for next week's tendon injury session, which I know is a very full and excellent program, and does include a therapist involvement. So I would encourage you to get your therapist to join as well. This presentation people have asked about will we be sharing the slides. We've definitely recorded the session and it will be accessible from the BSSH website as a YouTube video, so please do take advantage of that. You will get certificates. If Emma can share some slides, then I'm sure she will do so, as well as the certificates. We do welcome your feedback, so please do provide that when you get the opportunity. I guess my final task is to ask Samuel whether he wants to say a few words at the end.
From the Cossacks region, I mean, we have a good number of surgeons who are interested, general surgeons and orthopedic surgeons, and even clinical officers are the ones attending these cases, especially in our emergency department. And many cases are mismanaged or sent home without proper management. So this is the only way we can learn or we can disseminate the information. until when we get registered hand surgeons. Thank you.
So thank you, everyone. We look forward to seeing you again virtually, but particularly at some stage in the future, face to face. So thank you, everyone. Bye.
Bye.